Okay, welcome everyone. Welcome to our attendees who've joined us today, and for those joining via the recording, to the North Simcoe Muskoka Specialized Geriatric Services Practice Short for February 2025. Next slide, please. Thank you. So my name is Jackie Saul. I'm one of the psychogeriatric resource consultants with North Simcoe Muskoka Specialized Geriatric Services. And today we're going to start with a bit of a land acknowledgement, and then I'll turn it over to our guest speaker today. So this morning we're gathering on traditional lands sacred to many Indigenous nations. I would like to acknowledge the traditional territory of the Anishinaabeg, which includes the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy. The Haudenosaunee and Wendat nations, and the presence of other First Nations, Métis, and Inuit residing in Simcoe Muskoka territory. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. As such, we commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nation, Métis, and Inuit people. Today's session will be recorded and will be accessible on the Specialized Geriatric Services website. If you're watching the recording, welcome. And just as a reminder to everyone, our live practice short sessions are offered the second Friday of each month at 8:30 in the morning. So it gives me great pleasure this morning to introduce our speaker, Dr. Kitamura. Dr. Kitamura is a geriatric psychiatrist at Baycrest in Toronto. He's an assistant professor in the Department of Psychiatry, Division of Geriatric Psychiatry at the University of Toronto. He's the secretary of the Canadian Academy of Geriatric Psychiatry. He was a collaborator on the Canadian Coalition for Seniors Mental Health Substance Use Disorder Guidelines. He's the co-founder and co-chair of the Canadian Geriatric Substance Use Disorder Course for Geriatric Psychiatry Residents and International Geriatric Mental Health Education Network. He's presented widely on the topics of substance use disorders and optimal medication use in older adults. And welcome.
Great. Thanks so much, Jackie, and great to see everybody. And it's always wonderful to meet sort of new people in new settings. So it's my first time with this group. So although I recognize some of the names, I'm sure we've crossed paths in other settings. So I'm going to talk about substance use disorders in older adults, and it's an area of interest of mine. And as Jackie mentioned, both recreational as well as prescribed substances. We're going to do a bit of an overview generally, and then time permitting, we'll hone in on a couple of special topics at the end. I don't have any disclosures to share with you. Yeah, so we're going to talk a little bit about epidemiology and the impact of substance use disorders in older adults, talk a bit about diagnosis and treatment and some of the challenges and some of the tools out there to support these patients, and then again, a couple of special topics of dementia and driving, if we can get there. I just wanted to show that there is more attention, fortunately, being paid to the burden of substance use disorders in older adults. These are all articles from around the globe over the last few years. Obviously, this is an area that's got a lot more attention since the pandemic, and especially opioid overdoses. And you see the purple ribbons there on the top representing Overdose Awareness Day. But one thing that was not often talked about is the fact that it's older adults that saw some of the greatest, most significant increases in terms of substance use and disorders and impact. So just in a couple of slides, illustrating again some of the epidemiology, this is a map that shows the relative proportion of alcohol and drug use disorders that they play as a share of total disease burden. Okay, and obviously the darkest blocks here are up to 7% of total disease burden in the United States, but still significant proportions most places around the globe, with some relative sparing of some of the sub-Saharan African countries and Southeast Asia. And this is a graph too showing changes over time. So from 2000 up to actually before the pandemic. And it shows that the alcohol and drug use disorder deaths are increasing, and they're increasing in all age groups, but relatively the greatest increases are being seen in the 70 and older age group as it relates to substance use attributable deaths. Now, coming into focusing specifically on Canada, on the left is an image that speaks about substance use attributable inpatient hospital costs, okay, and by substance. So starting from alcohol and tobacco, and then others across the bottom. Alcohol and tobacco, of course, having a number of adverse effects on many bodily systems. And one thing to note in particular is the costs are greatest, often by far, in that 65 plus um, um, age bracket. So the costs are significant, and that's often, getting the attention of policymakers. And then on the right, just illustrating the fact that there are many indirect costs as well in terms of loss in productivity, criminal justice costs, and others. So it's more than just the healthcare system costs. Now, if we look at it by substance, what are the actual rates of use in Canada? And I mentioned already that they've been rising over the past 20 years. If we look at what's high risk alcohol use, and actually the definition of that is evolved a little bit, and I'll come back to that later about some of the different guidelines and what is too much alcohol. But high risk alcohol use in Canadian older adults, probably in the area of 12 to 15%. And higher in some other places around the world, such as the US and certain European countries. Tobacco use in older adults, however, has some of the highest rates in Canada, about 10%. Cannabis also, the rates of use in older adults in Canada is amongst the highest in the world, about 8%. And there isn't great data as far as sedative and opioid misuse. So there's not good stats, but there are problems around the world, including here. So why have the rates of substance use disorders increased in older adults over time? Well, there's a few explanations. One of them is that people are living longer and they're often using their substances for longer periods. And living longer, people often have more coexisting health issues. So with more of that polymorbidity, there's more potential for harms as well. Also, and this is relevant both to prescribed medicines and recreational substance use disorders, but there's more polypharmacy, right? People are older and they're sicker and they're on more complex regimens, so there's more potential for interactions and harms. Also, some effects of legislation, including legalization. We'll talk about that in a moment, as well as cultural and attitude changes over time. So here's one example of that. We know that obviously thinking back to the baby boomers who were the hippies in the 1970s, and now many of these individuals who were previously using substances to expand their awareness are often returning to use now later in life and have more of a progressive and open mind towards substances. So again, and one of the themes to keep in mind is that our older adults who use substances of all types, there could be two ways to get there: people who have used their whole life and people who are new users or return to use later in life. Both important. So now talking a little bit about legalization. Of course, nationally, the possession and use of cannabis was legalized in 2018 up to a certain amount. And there was a notable increase within the following year of harms, including emergency department visits, hospital admissions, and impaired driving related to cannabis use. And it's worth noting that the greatest proportion of new users were, in fact, older adults. Okay. And it remains that there's more harms from use, despite the fact that since legalization, there are more people obtaining their cannabis from legal sources and less likely from illicit sources. Good. Now, I want to talk a bit about decriminalization and start with just the example of Portugal. It's often cited. So legalization and decriminalization is a little bit different, right? Decriminalization means we're just going to take away, not enforce some of the criminal statutes, but it's not legal per se. But in Portugal, about 20 years ago, they took the approach that addiction was a health issue. And importantly, they moved resources from the criminal justice system to the healthcare system to support people with addictions. Decriminalized possession of all drugs, expanded treatment. The results of this, there was actually no increase in overall drug use, but there was reduced high-risk use, reduced drug-related deaths, and more people in treatment. Now, you're probably aware that in British Columbia, over the last 2 years, there has also been a decriminalization approach that was launched that has actually since been scrapped because of the fact that following decriminalization, they did see a continued increase in the number of overdose and deaths. A couple of things to say. One of them is we're talking about a pretty short time frame of 1 to 2 years, so it can be difficult to draw conclusions. Also, I don't think that the BC system took the same approach in terms of really trying to coordinate decriminalization with increased investment and access to healthcare services. And that may account to one possibility of why the outcomes have been a bit different. And in terms of, there's more attention just being paid generally to older adults and addictions. This is if you look in PubMed and you search addictions in older adults, you see, especially over the last 10 to 20 years, a significant increase in publications on this topic. There's also a number of guidelines that have come out. These are all in the last 10 years, from the left, from the UK and Australia. Of course, the CCSMH guidelines in 2019, I'll come back to that. And the United States as well also has regularly updated guidance of addictions in older adults. Okay, so this is the CCSMH. You see, I worked primarily on the benzodiazepine guidelines. The co-chairs at that time were David Kahn and Kieran Rabaru, and who since transitioned over to Dallas Sites. But the CCSMH put out 4 guidelines on the topics of alcohol, cannabis, benzos, and opioids. And they also have a really great cannabis and older adults e-learning module. All of this is free. There's patient tools and pocket guides and things like that you could find on their website. So check them out, ccsmh.ca, and look areas of focus to substance. Okay, and I don't want to talk too much just for the sake of time here, but person here on the top right is Nora Volko, who's from the States and was really one of the first people to articulate quite well that addictions are diseases of the brain, and talked about addictions developing in 3 phases. One of them is the brain's initial exposure to a substance, the release of dopamine, then the absence or the withdrawal of that substance, causing negative emotions, in the amygdala. And then, long story short, in the frontal lobes, there's kicks into gear a pattern of compulsive seeking and failure to inhibit the drive for the substance. Okay, so it kind of goes through these 3 cycles, and that's how kind of addiction is reinforced. And adapted from the CCSMH, of course, it's not just biology, but there are a number of psychosocial factors of addiction. Things to consider is history of trauma, certain coping styles and personality, for example, novelty seeking and impulsivity, the status of supports and relationships or lack thereof or ruptures, certain cultural views around substances. Certainly, we know that people in marginalized groups are at higher risk for and often related to the social determinants of health. And some factors specific to older adults include transitions and losses, such as retirement, the death of a spouse or friends, isolation and loneliness. It's another big area that the CCSMH is currently working on. Certainly elder abuse and ageism. It's important to consider. Come back to that. In terms of the effects of substances on the older adults and why older adults are more likely to encounter harms from same or even less amounts of use. There's greater sensitivity to the organs and tissues in older adults. Certainly the potential for drug-drug interactions, as I alluded to earlier. Older adults have reduced amounts of body water, so substances that are called hydrophilic are present in greater concentrations. They also have, older adults in general, higher fat content, so the lipophilic substances can actually stay in the body longer. And older adults have slower breakdown of substances through the kidney and breakdown through the liver and slower clearance of substances through the kidney. I mentioned more medical comorbidity, the effects of cognitive impairment in some older adults, which may impact their awareness of their use and harms and impede their ability to cut down. On the top of the table on the top right, and you can have a closer look later from the recording or the slides. I'm happy to have them shared. Basically, the substances can have many different effects, and many of them very non-specific, right? Including physical symptoms, injuries, nutrition difficulties, functional impairment, sleep disturbance, right? So really, anyone in isolation, not specific to the effect of substances, but if you see a lot of them happening together, definitely consider substances. Just a couple things about diagnosis in older adults. The DSM criteria in many ways are not a great fit for older adults. You know, some of the a couple examples of this. One of the criteria relates to increasing amounts of use, where older adults may encounter more harms with the same or less use. You know, persistent desire and unsuccessful efforts to cut down. Older adults, for example, those with cognitive impairment, may not have the awareness and ability. Some of the criteria for substance use disorders generally speak to impairments in roles, like impairments in the workplace, impairments with child rearing, impairments in the home, and some older adults may no longer have those roles or have different roles. Okay. Good. Oh, and also the issue around tolerance and withdrawal. Older adults are actually, on the whole, less likely to have a physical dependency to their substance. So again, they may not tick those boxes for diagnosis, and that often relates to the fact that older adults do encounter problems from lower amounts of use and not even regular or daily use as well. Some of the barriers to diagnosis, you know, where does geriatric addictions fall? It's kind of at the nexus. It's not really owned by any one particular discipline, either geriatrics or addictions medicine or psychiatry. The signs are non-specific. Biases are less likely to see it in females, in people of higher socioeconomic classes, in certain cultural groups, and also just thinking the idea of a late onset is a bit, still a newer idea to some people. The screening tools are not quite a fit, but I'll show you examples of some that are validated. And obviously access to training as well as treatments that are age appropriate and coordination of care, always a challenge in older adults. And you know, even the flow of government funding and research funding is not there for older adult addictions. And of course, ageism. So I'm going to come to that briefly. So stigma, just general, you can have self-stigma, you can have interpersonal stigma, and you can, of course, have stigma embedded in institutions. Stigma, when it translates to action, we call it discrimination. So a good example of discrimination for older adults and addictions would be older adults with opioid use disorders are less likely to be offered opioid agonist treatment in the emergent in hospital. Just one example. Certainly some ageist beliefs. I won't go through them all, but the idea that the substances are the only thing that's making them happy or making them happy, period, or that older adults don't benefit from treatment are not true. You might have heard of this idea of intersectionality, the idea that when you have older adult plus mental health issues plus addictions, it's almost like exponentially greater discrimination and stigmas. And ways to combat ageism, you know, involving the voices of people with lived experience and even just changing the language as well. Good. So a couple of screening tools. The only ones on this list that are developed specific to older adults are the two alcohol screening tools at the bottom, the MASG and the SAMI. And they're very good. But that said, there are some other other tools, not developed specifically for older adults, but which are validated in older adults. There's the ASSIST scale, which screens across a number of substances, the audit, the CAGE, you've heard for alcohol, and the QDIT for cannabis. Albeit the QDIT is the one on this list that has not been specifically validated in older adults, but still the best in terms of screening for cannabis use disorders. And saying just a couple of things about prescription drug misuse. There's a spectrum from clearly appropriate use to use disorders, but I wanted to highlight that there's some areas of gray in the middle. You know, for example, drugs that are being prescribed and used for questionable indications in amounts that are maybe concerning and failures to monitor the effects. There's a number of guidelines out there in terms of what is appropriate prescription drug misuse. You're probably familiar with Choosing Wisely and CCSMH I alluded to, and Jerry MedRisk, of course, here in Canada. AGS is out of the United States, and a couple other examples. So one resource I wanted to highlight here in Canada, that's great, is the deprescribing network. So if you go deprescribingnetwork.ca, one of the things they do great is they have some patient brochures related to helping to educate on the risks of certain prescription medication classes, such as the benzodiazepines, the sedative hypnotics. And it tells in plain language patients why they would want to cut back and also how to do it, and a little bit about some of the alternatives. For example, for sedatives, if they're being used for anxiety or sleep, some alternative approaches. And just giving patients these brochures, they're called the Empower brochure, can actually reduce use of these medications. Just for time, I'm going to jump, but there are some brief interventions. You might have heard of SBIRT, so screening, brief intervention, referral to treatment. The idea being here is to ask about use. People who have, low risk use or no use, you just want to educate. People who have more riskier patterns of use, you want to try to refer them on to formal treatment programs. Okay, and there's some good outcomes. There's good evidence that this SBIRT approach works. Okay, and just a couple of quick tips towards the end in the last 5 minutes. Around alcohol, I mentioned there's different guidance. The CCSMH 5 years ago said that limits for number of drinks per week should be 7 for men and 5 for females, with some non-drinking days. A couple years later, as you probably know, the Canadian Centre for Substance Use and Addiction, CCSA, came out with guidance on alcohol and health, and cautioned against any more than 2 drinks per week. Now, the idea being here, it's not that 2 drinks or more necessarily places someone at risk of physical dependency or an addiction, but just that more than 2 drinks a week does increase the risk of some health consequences. Okay, so some might say it's a little bit contradictory, but it's not quite, right? It's speaking about there's risk that develops over 2 drinks, and high risk drinking you can think of as following the CCSMH guidelines 7 and 5. For ongoing drinkers, especially heavy drinkers, consider supplementation with thiamine. Screening. There's actually a scale that helps to predict whether the degree of alcohol withdrawal somebody may encounter. It's the PAUSE scale. And obviously, if they score highly, consider any withdrawal being in a medically supervised setting. The anti-craving medications, naltrexone and acamprosate, work. And also, Marilyn White Campbell, one of my colleagues, is really big on using de-alkalized beverages. And these days, you can get non-alcoholic everything, right? All types of liquors, wine, certainly beers, but not limited to beers anymore. So, especially our patients with dementia, who they may have caregivers who are providing their alcohol, substituting some de-alkalized beverages can be quite handy. Saying a couple things just about cannabis briefly. The CCSMH guideline says if your patient has mental illness or cognitive impairment, cardiovascular disease, to really exercise caution if they're using any cannabis at all. And certainly there's different potencies of different strains, and so being aware of this. We often don't know, though, especially if it's procured from illicit sources, the potency. I'll come back to driving briefly in a second. There is syndromes of cannabis intoxication and withdrawal to be mindful of, but there's no evidence-based pharmacotherapies, nothing approved, no medications approved to treat cannabis use disorders. So I won't say too much here, just in the name of time, except that, of course, we don't know exactly, there's not good data of how much people with dementia are using substances. There's a number of mechanisms connecting dementia and substance use disorders, including impulsivity and self-medication of symptoms, and difficulties inhibiting, as I mentioned. Think about access to the substances, think about capacity, and if someone's not capable, for example, around anti-craving medications, consider getting substitute consent, okay? Also around finances, sometimes that's a way to control it. If somebody is making bad decisions, but they're capable decisions, that's one thing. But if somebody is has impaired decision-making, sometimes, taking over control of the finances may be the only way to limit. The evidence that any amount of alcohol or red wine is protective for the brain or cardiovascular disease is actually quite weak. And there's good evidence now that especially moderate or high amounts of use are toxic to the brain and actually a major risk factor for dementia. And I'll just say that any use of benzodiazepine does have is correlated with later development of dementia. Okay, but of course the causality here still needs to be established. But being on benzos does increase the likelihood someone's going to be diagnosed with a dementia later. And the last couple of slides. Older adults are driving while they're using alcohol and drugs. This is US data though. 6% of older adults say they drive impaired by alcohol or drugs. So keep this in mind. There's no good studies with benzos and driving, but Mark Rappaport in Toronto did do a simulation study where older adults on benzos in a simulator did have more problems with driving. Cannabis use here is actually the data so far is mixed. There was a meta-analysis a couple of years ago that said overall no increased risk. Then later that year, there was a large study out of the States that said older drivers who had recently used cannabis did have more motor vehicle accidents and traffic stops. Okay, and this is going to be shared with you, so maybe I won't go through them all, but Marilyn White Campbell has monthly rounds and a few other things you'll get I'll skip over that for questions. Just one last thing before I turn over to questions. It was mentioned earlier that I am a co-chair of International Geriatric Mental Health Rounds. We run monthly rounds. We have a WhatsApp group. Our next session is actually next Friday. It's a great group from all around the world that joins. It's a lot of allied health. It's not a sort of physician-dominated discussion, so it's really welcoming, I think, to everybody, and it's free. So join us, and there'll be a registration link in our WhatsApp link down at the bottom. Should I stop sharing, Jackie? Oh, actually, no, you have
Yeah,
a
that's
couple.
great.
You want to do your slides first,
Sure.
or
I was just going to draw everyone's attention to practice short for next month, discussion about young onset dementia. Allison has put resources in the chat for everybody, so you can register now. Registration is open. You could go to the next slide if you want. And then we've got our focus on geriatric pharmacotherapy, March 5th, 1 to 5 p.m. on Zoom. Registration is open for that as well. So you can check that out. And then refer to our website for all of our upcoming education offerings through NSMSGS. We do have some openings still for some gentle persuasive approach and positive approach to care in March. So check that out if you're interested. We did have a couple of questions for you.
yeah.
So I thought we would try to get to those.
Mhm.
So lots of accolades in the chat and the Q&A box. Excellent presentation. Someone's asking here about the intersectionality for biases. I love your response to it's the only thing that makes them happy. Do you have any suggestions about how clinicians can approach this conversation with older adults or family members who may know this as a lifelong habit?
Yeah, so it's I mean, I think it relates to some of the biases that, that a lot of people harbor, maybe unconsciously to older adults, that things can't change, but they're not capable of change. They won't benefit from change. Why are you taking something that gives them pleasure away? But I think that the big picture is just sharing the evidence that we do know that alcohol is a depressant, right? Most substances, especially if used chronically or certainly in large amounts, have negative effects on psychiatric symptoms and functioning. So it actually is frankly a myth, right? That people are feeling better, happier, doing better with them, and just trying to convey that message.
Mhm. Thank you. We have another question here. When suggesting family to substitute with non-alcoholic drinks, should nurses be advising that in case of withdrawal symptoms, what's the best way to start substituting?
Yeah, so I would think of substituting. It's you're substituting while you're tapering. Yeah, so it's a great point. It's not certainly if someone is using regularly and high amounts of use and it stopped suddenly, there will be likely some degree of withdrawal. So that's not what we want to do. So it's kind of phasing down the alcoholic beverages and adding in the non-alcoholic. Some people do this by diluting, right? The bottle of whiskey, dump out half, fill the other half with water, and then that's a way. If you're pouring out the same amount of a drink, right? That's tapering as well. Yeah, it's a good point.
Yeah, great strategy there. And the last question is thanks so much for the fantastic talk. Wondering about the difference between legalization and decriminalization.
Yeah, so they're different. Legalization, like cannabis in Canada, saying that it's allowable, right, to have cannabis up to 30 grams. Decriminalization, it says it's not legal, and you're not allowed to do it, but we're not going to enforce, any criminal statutes. So that's really what the difference is. So BC was an example of decriminalization. They didn't legalize drugs, they decriminalized them. And again, it's seemingly halfway sort of out the window now, but we'll see what happens.
Yeah. All right. Do we have time for one last question?
Yeah,
Okay.
yeah, from my end, yeah, certainly. I'm
Okay.
happy to stay back a little bit too.
One last one, and then we'll shut it down. Just being mindful of time. So, thoughts, suggestions about when working with families who enable substance use because of the irritability when the person does not have access to it.
Yeah, no, it's a great point. And in those cases, I mean, it could be in part withdrawal, right? We know irritability is a symptom of withdrawal, and maybe the alcohol was suddenly stopped, as we heard earlier, or not, and they may actually need, some appropriate treatment of withdrawal symptoms, like on a CEWA protocol, would be benzodiazepine medications, for example. But it also makes me think that the irritability may be exposing another symptom, right? Maybe it's a BPSD, maybe it's underlying mood or anxiety disorder, and those conditions, right, need appropriate treatment in their own right, right? So I think that's the way to think about it. Is there another condition that's not being optimally treated that might be fueling the alcohol and that power struggle, right?
Yeah, absolutely. All interconnected, right?
Yeah. Yeah.
Thank you so much for your time this morning, Dr. Kitamura, and for speaking with us. It was a wonderful talk. Thank you so much.
Good. Nice to see everybody.
Have a
Okay.
great long
Have
weekend.
a great weekend.
Take care.